All right, I got a presentation here on some advancement material for the March 2018 exam. This presentation is just going to be a quick review. It's not going to be like the previous videos where I did more of a a thorough explanation of what's going on with each instruction. This is strictly review. This is stuff I've either already made a video of or I've been covering with my guys that I work with getting ready for this March 2018 exam. So it's going to be a little different than what most of the videos have been before. All right, so let's start with our 6,000 SSIC codes. It's important to know what those are. Anything just 6,000, that's going to be general admin as it pertains to medicine. 61, that's going to be physical fitness. 6,200, that's going to fall under preventative medicine. 63, general medicine. 64 through 65, that's our special fields. 66 is dental, and 67 through 68, that's going to be equipment and supplies. So these 6,000 instructions that we got to know for this advancement exam coming up. With 6,000, our general admin one, that's going to be QA instruction, the quality assurance instruction, BioMed instruction 601013. Physical fitness is going to be our deployment health assessment and our PHA. Deployment health assessment, remember that's an OPNAV instruction 6103 alpha, and then our PHA for individual medical readiness, that's a Secretary of the Navy SecNav instruction 6120.3. Prev Med, that's where the bulk of the instructions are going to fall under. Preventative medicine, we've got 6229 Bravo for hospital-acquired infections. We've got 6220.12 for medical surveillance, 622030.15 for immunizations, and then 6250 Malaria Pocket Guide, our publication from the Navy Marine Corps Public Health Center on malaria. We got chapter 1 on this exam coming up, and then 6280.1 for our regulated medical waste. General medicine, the two instructions we've got the primary care, BioMed instruction 6319, and we've got customer relations program 6310 Bravo. Special fields, we've got the augmentation program with 6440.5, and we've got the diagnostic imaging equipment and performance with 6470.22. Nothing in dentistry, but we do have one that pertains to supply, equipment and supply, and that was the 6710.63, unsafe, unsat medical and dental material. All right, so we'll start this off with some review of the quality assurance program. What instruction is the QA program? What's the instruction for the QA program? No, that's BioMed instruction 6010.13. What term describes an event or outcome during the process of medical or dental care in which a patient suffers a lack of improvement or injury or illness of severity greater than ordinarily experienced by patients with a similar procedure or illness? So somebody who's not getting better at the expected rate or has some sort of accident or injury during a treatment, we're going to call that a PCE, a potentially compensable event. A potentially compensable event. All right, what are the classifications of injury or disability? So we classify these PCEs in 3 different classifications. We've got none or minor, we've got temporary, and we've got long-term permanent. Those are our 3 classifications: none or minor, temporary, and long-term permanent. So what classification is a healed forearm fracture with loss of motion in the wrist and elbow or elbow? Healed forearm fracture with a loss of motion in the wrist or elbow is long-term permanent. That's a long-term permanent injury. Fracture of a tooth during anesthesia. What classification is a fracture of a tooth during anesthesia? We're going to call that temporary. Fall with a resultant neurological injury. Fall with a neuro injury, that's going to be long-term permanent. Appendectomy surgery for perforated appendix with no delay in recovery. Appendectomy surgery with a perforated or for perforated appendix with no delay in recovery, that's none or minor. Falls with laceration or fracture. A fall with a laceration or fracture, that's temporary. Loss of a thumb or a finger. Loss of a thumb or a finger, that's a long-term permanent injury. Single episode of post-operative sepsis. A single episode of post-operative sepsis, that's going to be a temporary. Anesthetic-related cardiac or respiratory arrests. Anesthetic-related cardiac or respiratory arrests, that's a long-term permanent. Post-operative inadvertent retention of a foreign body. Leaving something in somebody after surgery, well, that's going to be long-term permanent. Delayed recovery from anesthesia, not impeding the overall recovery. A delayed recovery from anesthesia, but everything else is okay. Well, that's none or minor. Incisional hernia. An incisional hernia, we're going to classify that as temporary. Misdiagnosis of fracture recognized at a later date, but healing with no residual deformity. Didn't catch the fracture on the initial visit, but it's healing and it's not a problem. That's none or minor. Delayed union of a fracture. Delayed union of a fracture, we're going to call that temporary. Moving on, how many years is the QA program related documentation maintained? For how many years do we have to hold on to QA related documentation? That's 5 years. 5 years we're holding on to that. What's the minimum time QA inquiries and medical records related to PCEs and JAG investigations have to be maintained? How long do we have to hold on to PCE or JAG investigation paperwork? Well, we keep a hold of that stuff for only 2 years. 2 years on inquiries into PCEs and JAG investigations. The preceding fiscal year's annual assessment of an MTF's and DTF's QA program must reach BMed by what date? When is the annual assessment of an MTF's QA program due to BMed by? It's due by the 15th of January, 15 January. What instruction is management of regulated medical waste? What instruction is management of regulated medical waste? That's BMed instruction 6280.1. 6280.1. How many groups of regulated medical waste are there? How many groups of regulated medical waste are there? There are 9 groups. 9 groups of regulated medical waste. And then what are the 9 groups? I recommend you come up with some sort of acronym or ditty or something to memorize these by. I just do it by chunking it into CPBS AI SOC. That works for me, but I'm sure there's better ones out there. But 1, that's cultures and stocks. 2, that's pathological waste. 3, blood and blood products. 4, sharps. 5 is animal waste for A. 6 is isolation waste. 7, unused sharps. 8, other, and 9, chemotherapy waste. Those are our 9 groups of regulated medical waste. 1, cultures and stocks. 2, pathological waste. 3, blood and blood products. 4, used sharps. 5, animal waste. 6, isolation waste. 7, unused sharps. 8, other, and 9, chemotherapy waste. How many biosafety levels are there? How many biosafety levels are there? There are 4 biosafety levels. What is the most stringent of the biosafety levels? What is the most stringent of the biosafety levels? That 4th level, level 4. How must pathological waste be stored? If we're keeping it on site, how do we store it? It's got to be refrigerated or frozen. When is pathological waste required to be frozen? When do you got to freeze it? Well, that's if we're going to keep it on site for longer than 24 hours. So pathological waste has got to be refrigerated or frozen if we're going to keep it longer than 24 hours. How long can non-pathological regulated medical waste be placed in storage? So if it's not pathological, how long can we keep it in storage? Well, we can do that up to 7 days. 7 days for non-pathological regulated medical waste. We can keep. Okay, moving on to respirators. So first off, what instruction can I find guidance on respiratory use in the respiratory protection program, the respiratory protection program? Well, you can find that in OPNAV 5119, our safety and occupational health afloat. So respirators, what are the 2 types of respirators? We broadly divide respirators into air purifying and atmosphere supplying. What defines sufficient oxygen? Sufficient oxygen is 19.5%, and we need sufficient oxygen to use air purifying respirators because that's just filtering the air that's already available in the atmosphere. What are the 2 types of air purifying respirators? So for air purifying respirators, we've got powered air purifying respirators and non-powered. Who certifies respirators? Who certifies all our respirators? Well, respirators got to be approved by NIOSH, the National Institute of Occupational Safety and Health. How many classifications of non-powered air purifying respirators are there? We've got 9 classifications. What are the 3 filter classes? The 3 filter classes are NRP. So we have got 3 filter classes and they all have 3 levels of efficiency. That's how you get to the 9 classifications. But the 3 filter classes, NRP, remember that the P class is going to be color coded. It's either going to be purple or magenta, and we can use that in oil aerosols. The R class, you can use it in oil aerosols, but only for 1 shift. And then the N class, you cannot use in the presence of oil aerosols at all. What are the two types of atmosphere supplying respirators? Our atmosphere supplying respirator is going to be supplied air and the self-contained breathing apparatus, or the SCBA. What is the maximum hose length on an airline respirator? The maximum hose length on an airline respirator is 300 feet, and that's a NIOSH standard. What is the special SCBA used by the Navy to escape fires? What is the special SCBA used by the Navy to escape fires? Well, that's going to be the EEBD, the Emergency Escape Breathing Device, or the SEED, the Supplemental Emergency Escape Device. How often is respirator fit testing conducted? How often is respirator fit testing conducted? Well, respirator fit testing has to be done at the initial issue of the respirator and then annually thereafter. You got to get fit tested every year. How often are emergency respirators inspected? How often are emergency respirators inspected? They're going to be inspected after every use and monthly. After every use and at least monthly. How long are inspection reports on emergency respirators maintained? For how long do we keep the inspection reports on emergency respirators? We're going to keep those for the life of the respirator, If entering an atmosphere that's immediately dangerous to life and health, IDLH, with an airline respirator, what additional equipment do you got to take on you? All right, so if you're using an airline respirator and you're entering an area immediately dangerous to life and health, you got to take at least 15 minutes of self-contained auxiliary air supply. 15 minutes of air got to go with you. How often are emergency respirators inspected? Emergency respirators inspected after each use and at least monthly. Within how many months must a respiratory protection program management course be attended by a newly assigned respiratory protection manager? Within how many months do they have once being assigned a respiratory protection manager? Got to attend that course within 3 months. How often must a respiratory protection manager evaluate the respiratory protection program? Well, the RPMs, he or she's got to inspect their program at least annually. When are atmosphere supplying respirators required? When do we have to use atmosphere supplying respirators? Well, we got to use that if these three conditions exist. If the contaminant has no warning property, if the contaminant's concentration is too high for air purifying respirators, and if the environment is immediately dangerous to life and health. Cannot use air purifying, got to use an atmosphere supplying respirator if those three things occur, right? The contaminant has no warning property, the contaminant's too high in concentration, and the environment is immediately dangerous to life and health. Okay, moving on to hearing conservation, still in the OPNAV 5119. What noise level is considered hazardous? When have we reached hazardous noise? Well, we define hazardous noise as greater than 84 decibels at a time-weighted average or 140 peak pressure, right? Just getting those peak sounds of 140 decibels. So above 84 time-weighted average or 140 peak. What is utilized to label noise hazardous areas and equipment? What do we utilize to label noise hazardous areas and equipment? Well, we're going to use a NAVMED form, and since it's we're trying to prevent hearing loss, it's a 62, right? So NAVMED 6260/2 and the NAVMED 6260/2A. That's the decal and the label. The decal to go on the outside of a door entering a noise hazardous area, and the label to label individual equipment. NAVMED 6260/2 and /2 alpha. What form is our reference audiogram? What form is the reference audiogram? Reference audiogram is going to be a DD2215. DD2215. What system are annual hearing tests entered into? The annual audiogram is going to be entered into the DOERS HC. DOERS HC, Defense Occupational Environmental Health Reporting System, TAC Hearing Conservation. DOERS HC. When is a WES entry required? The Web-Enabled Safety System. When is a WES entry required? Well, when we have an STS that averages 10 and the frequencies 2,000 through 4,000 hertz, or a total hearing loss 25 decibels or more in the same ear. What is considered an STS? What is a significant threshold shift on an audiogram? STS, we're going to say, is a change in 15 decibels or higher at any testing frequency from 1,000 to 4,000 in either ear, or an average of 10 decibels in the frequencies 2,000, 3,000, and 4,000. So two ways you can have an STS: a change of 15 or higher, or an average of 10 in the frequencies 2, 3, and 4,000 hertz. If a service member has a significant threshold shift on their annual audiogram, at a minimum, how long should they be excluded from noise hazards before they retest? If you have an STS, how much rest do you need? How much auditory rest? How long do you got to be excluded from a noise hazard? Got to be excluded for at least 14 hours. 14 hours. How often do audiometric chambers need to be recalibrated? How often do audiometric chambers need to be recalibrated? That's got to be done annually. So moving on to our deployment health assessments. What instruction is the deployment health assessment? What instruction is the deployment health assessment? That's OpNav instruction, has to do with readiness, so 61. So OpNav instruction 6100.3, that's our deployment health assessment. Who are considered frequent deployers? Who is considered a frequent deployer? A frequent deployer is someone who deploys more than one 30-day period in 12 months, so at least two 30-day deployments in a 12-month window. When are post-deployment health reassessments completed on frequent deployers? When are PDHRAs completed on frequent deployers? Well, we're just going to catch that during their annual PHA. During their annual periodic health assessment, that's when we'll do the deployment health assessments. What form is a PAR-FQ? What form is a PAR-FQ? Well, the PAR-FQ is a NAV-PERS form, so it's NAV-PERS, but it is a Navy form, so it follows our SSICs. NAV-PERS 6110/3 has to do with readiness, right? Physical readiness. NAV-PERS 6110/3. What form numbers are the pre, post, and post-deployment reassessment? Pre, post, and post-deployment reassessment forms were their DD forms. So we've got DD 2795 for the pre-deployment, DD 2796 for the post-deployment health assessment, and then we jump up to DD 2900 for the post-deployment health reassessment. What are the time frames in which each needs to be completed? So in relation to the deployment, the pre-deployment health assessment, our 2795, that needs to be done no earlier than 120 days prior to the deployment. You want to do it in that 120-day window to the deployment. The post-deployment health assessment, well, that one can be done 30 days plus or minus the redeployment. So remember, redeployment means coming home. So we could do it 30 days before coming home or 30 days after coming home. 30 days plus or minus the redeployment. And then the 2900, the post-deployment health reassessment, that one's going to be completed 90 to 180 days after returning. 90 to 180 days. Moving on to our malaria handbook from the Navy Marine Corps Public Health Center. So what are the 4 species of malaria that rely on man? What are the 4 species of malaria that rely on man? Well, we've got Plasmodium falciparum, Plasmodium vivax, Malariae, and Plasmodium ovale. What mosquito transmits malaria? What mosquito transmits malaria? Well, that's going to be the female Anopheles mosquito. Of the 4 species of malaria, which 2 have a dormant liver phase? Of the 4, which 2 have a dormant liver phase? Well, that's going to be Plasmodium vivax and Plasmodium ovale. Where can you find detailed country-specific information on the malaria burden in a country? Where can you find detailed country-specific information on the malaria burden in a country? Well, you can find that at the National Center for Medical Intelligence or the Cognizant Navy Environmental Preventive Medicine Unit. All right, so the National Center for Medical Intelligence or the Cognizant NEPU. Moving on to our PHA instruction. What instruction is our PHA instruction? What instruction is for PHAs? The periodic health assessment. So that has to do with readiness. So it'll be a 61. It's published by the Secretary of the Navy. So SecNav instruction. SecNav instruction 6120.3 is our PHA. What are the 6 elements of a service member's individual medical readiness? What are the 6 elements of an IMR? IMR is made up of individual medical equipment, immunizations, laboratory studies, dental readiness, deployment limited conditions, and then the PHA itself. Medical equipment, immunizations, laboratory studies, dental, deployment limiting conditions like being on LIMDU or postpartum, and then the PHA. Those are the 6 things that make up somebody's IMR. Who are considered approved providers with authorization to review and sign PHAs? Who can review and sign PHAs? Well, your independent duty corpsmen can do that, physicians, nurse practitioners, and physician assistants, PAs. Those are the only approved providers who can review and sign a PHA. Visual acuity worse than blank requires referral to optometry. If your visual acuity is worse than blank, then that number is 2040. Visual acuity worse than 2040, got to send them to optometry. What is utilized to test distance binocular visual acuity during the PHA? If we're going to look at that distal visual acuity, we're going to use that Snellen chart. At what age is near binocular visual acuity testing required during the PHA? At what age do we got to start testing that near vision? When we get greater than 45 years of age. How far is a near acuity card held when testing for near vision? How far do you hold that card? We're going to hold it 16 inches away. If a service member requires corrective lenses, what medical equipment must be verified during the PHA? If you wear corrective lenses, part of that medical equipment on your IMR has got to be verified during that PHA. So we've got to make sure you got 2 pairs of those prescription glasses, that you've got protective gas mask inserts, and that you've got ballistic optical inserts as well. What immunizations are required for deployment? So what are your minimum immunizations required? Non-region specific, right? We have to get smallpox for certain places, anthrax for certain places. That's not what we're talking about here. Just a minimum immunization somebody needs. Minimum IMS, hepatitis A and B, inactivated polio vaccine, Tdap, MMR, measles, mumps, and rubella, and influenza. Those are the minimum immunizations. Hepatitis A and B, inactivated polio vaccine, Tdap, MMR, and influenza. What is included in the readiness lab studies that require verification during the PHA? What are the readiness lab studies that got to be verified during the PHA? We've got to make sure that we've got your ABO blood type with the RH factor, that we got your G6PD status, and then we got a DNA specimen, and that your HIV is up to date. What dental classifications are considered worldwide deployable? What dental classifications are worldwide deployable? Well, that's class 1 and 2. What type of exam is the annual dental exam? What type of exam is the annual dental exam? That's your type 2 exam, type 2. What 3 forms are used in the deployment health assessment process? What 3 forms, right? PHA can't be completed unless the deployment health assessment is done, so that's how these 2 instructions can tie in together, right? So we talked about these forms already. We've got a DD 2795 for the pre, DD 2796 for the post, and the post-deployment health reassessment is going to jump up to the DD 2900. Right. In what chapter of the P117 would you find guidance on female-specific health screenings? So first off, what's your P117? Well, that's your manual of the medical department. What chapter can you find female-specific health screening? Well, you can find that in Chapter 15, Physical Exams. All right, moving on to Chapter 21. Chapter 21 of our ManMed, all right, pharmacy operations. So I'm just going to talk real quick about the different scheduled medications and how many refills can be done in each schedule, how many days supply can be issued when we're CONUS, when we're staying here, are our deployment supplies. So Schedule 2, right, the one with the highest abuse potential but still some acceptable medicinal use. Schedule 2, that's got to be filled within 30 days of the prescription being written. Max supply is 30 days. We can do deployment supplies at 90 days, and there's no refills. No refills on Schedule 2. Each script is a new script. If you need more of that, you got to get a new prescription. No refills. And then there is an exception if it's a stimulant type medication, like for attention deficit disorder or something like that. They can do a 100-day supply for stimulant medications that are Scheduled 2. But for the most part, they limit it to 30 days. So filled within 30 days, max supply of 30 days. We can do a 90-day supply for deployers, but no refills. And then we make the exception for stimulant medications. You can do up to 100 days. All right, moving on to Schedule 3, 4, and 5. Those got to be filled within 6 months. The max supply is 100 days, a deployment supply of 180 days, and up to 5 refills in a 6-month period. So Schedule 3, 4, and 5, fill them in 6 months, 100-day supply max. Our deployers can get 180-day supply and then 5 refills within a 6-month period. Non-controlled medications, we just got to get those filled within a year. Max supply day is usually kept around 100. Refill anytime within that 12 months of the original prescription date. And then one exception of that would be like oral contraceptives. We can give up to 6 months at a time a lot of times with these. So your exception would be would be your oral contraceptives. A lot of times we'll do 6-month supply at once with a refill, get somebody through a year for that. Right, what form is the DoD prescription? What form is the DoD prescription? So just by the nature, Department of the Defense, right? Department of Defense is going to be a DD form, so it's DD 1289. DD 1289. What form is a poly prescription? What form is a poly prescription? Well, polyscript is a Navy form, so it's a NavMed, right? NavMed 6710/6 follows your SSICs, right? We think of pharmacy as supply, so it's a 67, right? 6710/6 is your poly prescription. What medication schedules can be stored in a locked cabinet? What medication schedules can be stored in a locked cabinet? Well, we can store schedule 3, 4, and 5 in a locked cabinet. How many members are required to be on a controlled substance inventory board? How many members are required to be on a controlled substance inventory board? 3, and 1's got to be a commissioned officer. The other rank requirements, they've got to be the equivalent of a chief or above, okay? So chief and above for the other members, and at least 1, the senior CSIB member, has to be a commissioned officer. How are schedule 1 and 2 medications stored? Right, so we said 3, 4, and 5 can go in a locked cabinet. Schedule 1 and 2, well, those got to be stored in a vault or a safe or a vault for schedule 1 and 2. Not a question on here, but I'll go ahead and ask it. How often is the combination on the safe or the vault changed? How often is the combo changed? It's got to be changed every 6 months. Where's the combo kept? The combo is kept with the CO in a sealed envelope or somebody designated in writing. What form is used in cases of theft or significant loss of narcotics? What form is going to be used when we find out that narcotics are stolen or lost? We're going to use the DEA Form 106. DEA Form 106. Where is the DEA Form 106 sent? Where do we send the DEA Form 106? We're going to send that to the nearest DEA regional office. So the original is going to go there with copies to BUMED Pharmacy Specialty Leader, the MTF, the Medical Treatment Facility Regional Pharmacy Representative, and the nearest NCIS Field Representative. So the DE form, when we fill that out, anytime we have a significant loss of narcotics or theft of narcotics, we got to send it to the DEA Regional Office, the BUMED Pharmacy Specialty Leader, the MTF Regional Pharmacy Representative, and the nearest NCIS Field Representative. Moving on to our Med Inspector General program. So what instruction is our Med Inspector General program instruction? That's BUMED Instruction 5040.2. What finding describes a non-existent program or one that is deficient in major elements so it does not fulfill the intent of policy? So when the MEDINSGEN comes and inspects programs, what finding is for a program that is deficient in major elements or doesn't exist? That's going to be an RFI, a requirement for improvement. So when the MEDINSGEN comes and inspects programs, they can give you RFI, which is the worst one, saying you don't have this program. Supplemental, saying, hey, you're almost there, but not quite. Opportunity for improvement, hey, everything's good, you're meeting policy, but we can do some things to help you out, make it a little bit more efficient. And then they can just say you're compliant. So RFI, right, a non-existent program or one that is deficient in major elements so it does not fulfill the intent of policy. Right? What must a command respond with if they receive an RFI? If a command receives an RFI, they've got to respond with an ISR, an Implementation Status Report, an ISR. What form is the ISR documented on? What form is the ISR documented on? What's documented on an OPNAV form? So OPNAV 5040/2. OPNAV 5040/2. Right? Same numbering as the instruction. OPNAV 5040/2. When is the ISR due? When is the Implementation Status Report due after the command's received an RFI? Well, that's going to be due within 60 days. Okay? ISR submitted on the OPNAV 5040/2 within 60 days. When are follow-on ISRs due? So after that initial one, if the RFI stays open, when are the follow-on ISRs due? They're going to be due every 90 days. Every 90 days until that RFI is deemed closed. If the RFI remains open for greater than a year, what is required from the command? If the requirement for improvement is open for greater than 1 year, the command's got to respond with a letter to the regional commander explaining why the RFI still is open. What Med Inspector General finding identifies a program that has an effective and formal process in place but requires modification to achieve full compliance? Right? A program that has effective and formal processes in place but requires modification to achieve full compliance, well, that's a supplemental finding. CONUS Navy Medicine Commands will receive how many days notice of an impending Med Inspector General or Joint Commission inspection? How many days does CONUS get in advance? They get 7 business days. OCONUS, how many days in advance does OCONUS get? They get 30 business days. All right, what instruction is our primary care services in Navy medicine? What is our primary care in Navy medicine? That's a BUMED instruction 6319. 6300 just falls under general medicine. What organization has established the nationally recognized standards for patient-centered medical home and medical home port? Well, that's the NCQA, the National Committee for Quality Assurance. Within how many months will a new medical home port clinic attain level 1 NCQA recognition? So a clinic wants to become a level 1, they got 4 months to get that done. 4 months. After obtaining level 1 NCQA recognition, how many months does a medical home port clinic have to achieve level 2 recognition? Well, after level 1, you only got 6 months. 6 months, so you get 10 months total to get to NCQA level 2. Who does the commander, the CO, or the OIC of an MTF notify when they feel that their clinic is ready for NCQA level 2 recognition? So NCQA level 1, that's just done through self-assessment. In order for a clinic to get NCQA level 2, they've got to start to reach out. The first person the OIC or the CO is going to reach out to is the regional commander. They'll reach out to Navy Medicine Regional Commander. Who does Navy Medicine Regional Commander forward the clinic NCQA level 2 recognition request to? Well, they're going to go ahead and forward that up to BUMED, okay? So the Bureau of Medicine and Surgery. How many bookable hours does a clinician require to be considered a 1.0 FTE, which stands for full-time equivalent? How many bookable hours does a clinician require to be considered a 1.0 FTE? They got to have 36 bookable hours, 36 hours available for appointments. What is a recommended empanelment range for a provider? How many patients should be empaneled to a single provider? Well, BUMED wants us to keep it at 1,100 to 1,300. Okay, 1,100 to 1,300 maximum. What are the exceptions a home port clinic can make when providing care to patients not enrolled in their home port team? So your empaneled patients have to be enrolled. You're not supposed to see anybody outside the empaneled patients, with a couple exceptions. And those exceptions are newborns of patients less than 60 days old, right? And then foreign nationals or dignitaries. Newborns less than 60 days old, and then foreign nationals or dignitaries. Students cannot be enrolled at home port if they are stationed less than how many days? Students cannot be enrolled in home port if they are stationed less than how many days? Less than 179 days. If you're stationed less than 179 days, you don't get a PCM. What percentage of a provider team should be made up of civilians? What percentage of a provider team should be made of civilians? We want 50% of the team to be made up of civilians, just so we can make the adjustments when the providers deploy. In a 3-provider team, how many providers have to be physicians, and then what is their maximum administrative discount for the team? A 3-provider team has to have 1 physician, and they get 0.75 full-time equivalent FTE administrative discounts. 1 physician and 0.75 administrative discounts, FTEs that is. 4-provider team. How many have to be a physician, and what are their administrative discounts? Well, a 4-provider team, you got to have 2 physicians, and they get 1.0 FTE for administrative discounts. And then a 5-provider team, how many physicians, and then what's the administrative discount? Well, we still need only 2 physicians for a 5-provider team, but they get 1.25 FTE administrative discounts. How many exam rooms are required per provider? How many exam rooms are required per provider? Well, each provider should have 2 exam rooms. 2 exam rooms. All right, moving on to medical surveillance. All right, what instruction is the medical surveillance and medical event reporting? What instruction is med surveillance and medical event reporting? That's BUMED instruction 6220.12 Charlie. 6220, right? Preventative medicine, that tertiary 2 right there, well, communicable disease, that's what this is all about, reporting highly contagious diseases. Who is the Department of the Navy's hub for surveillance reporting? Who is the Department of the Navy's hub for surveillance reporting? Well, that's the Navy Marine Corps Public Health Center, the NMCP-HC, Navy Marine Corps Public Health Center. Who publishes the agreed upon reportable medical events list? Who publishes the agreed upon reportable medical events list? Well, that's the Armed Forces Health Surveillance Center. Armed Forces Health Surveillance Center. What are the two types of medical event reports? What are the two types of MERS, medical event reports? We've got an urgent and we've got a routine MER. What are the deadlines? What are the deadlines for the two different MERS, the medical event reports? An urgent has to be done within 24 hours and a routine no later than 7 calendar days. No later than 7 calendar days. What is the Navy's official system to submit, view, and track medical event reports? What's the Navy's official system to view and submit and track their MERS? Well, that's going to be done on DRSI. DRSI, the Disease Reporting System Internet. What are other ways a MER can be submitted? What are some other ways we can do a medical event report? We can do it through a phone, we can do it through a naval message or an email. And who are we going to submit them to? We're going to submit them to the Cognizant Navy Environmental Preventive Medicine Unit. All right, just going to go over a list of the reportable medical events that require urgent notification that have to be done within 24 hours, have to be reported within 24 hours. So anthrax, botulism, diphtheria, hemorrhagic fever, novel influenza A, malaria, measles, meningococcal disease, any outbreaks or disease clusters, plague, poliomyelitis, rabies, SARS, smallpox, tuberculosis, and tularemia. These all got to be submitted within 24 hours. These require urgent reportable medical events, okay? Anthrax, botulism, diphtheria, hemorrhagic fever, novel influenza A, malaria, measles, meningococcal disease, any outbreaks or disease clusters, plague, polio, rabies, SARS, smallpox, tuberculosis, and tularemia all require an urgent report. All right, let's talk about Chapter 9 in the P5010, Preventative Medicine for Ground Forces. What are potential water sources? What are some potential water sources? Well, our potential water sources for ground forces include existing public water, surface water, groundwater, salt water, and other. What is the most common field purification system in use? What is the most common field purification system in use? That's your ROPU, your reverse osmosis water purification unit. What is the most common method of disinfecting water? What is the most common method of disinfecting water? Well, we're going to use chlorination in the field. What is the preferred agent for chlorination? What is our preferred agent for chlorination? We're going to use calcium hypochlorite, HTH 65 to 70%, calcium hypochlorite. What's the other less convenient method? What else can we use? We can use sodium hypochlorite, which is just bleach. When should you read the free available chlorine after chlorinating? So we add some chlorine to the drinking water. When do we read it? We read it 30 minutes after. 30 minutes after, that's when you're going to read the free available chlorine. What level of free available chlorine must be reached to superchlorinate a water container? So we want to disinfect this water bowl over here. What level are we supposed to reach? We got to get it up to 100 parts per million. 100 parts per million. What level must it maintain and for how long? Well, it cannot drop below 50 parts per million, and that's for 4 hours. So initially get it up to 100 parts per million. Do not let it drop below 50 parts per million, and it's got to stay that way for 4 hours. What else must be done to the water container when we're superchlorinating? So when we're superchlorinating, we got to mark the container with the words "poison, do not drink." Right? It's got to be clearly displayed on each side and anywhere where water can come out. Okay, at any water outlets or spigots. What color should iodine tablets be? What color should iodine be? Iodine should be steel gray. How many iodine tablets to disinfect a canteen? How many iodine tablets to disinfect a normal canteen? Well, that's 2 tablets. It takes 2 tablets. What if it's a 2-quart canteen? We'll just double it up. 4 tablets. 4 iodine tablets for a 2-quart canteen. How many iodine tablets for a 5-gallon container? 5-gallon container is going to take 40 iodine tablets. 40 iodine tablets. What is a procedure for purifying water with iodine? What is a procedure for purifying water with iodine? Well, first you add the iodine tablets. Next, you place the cap on loosely. You wait 5 minutes, and then you shake the canteen, allow for the water to leak around and rinse the threads around the neck of the canteen, and then you tighten the cap and you wait for 30 minutes before using the water, so the whole process will take you 35 minutes. How long must you bring water to a rolling boil? So if you're going to boil your water to disinfect it, you got to bring it to a rolling boil for at least 2 minutes. 2 minutes. All right, how often must water containers be disinfected? How often must water containers be disinfected? Whenever necessary, but not less than monthly. Not less than monthly to disinfect water containers. How often is free available chlorine tested? Free available chlorine, you got to test that daily. Once daily, you got to test the chlorine levels in your water. How often is water tested for bacteria? How often do we test for bacteria? We're going to do that on a weekly basis. What must happen if a distribution system is positive for bacteria? So if a distribution system tests positive for bacteria, well, we got to make sure to test the area we got it from again, and then we got to test within five distribution points upstream and 5 downstream. All right, how often are temperature readings on filled refrigerators and freezers recorded? How often do we got to record temperatures on filled reefers and freezers? We got to do that with each meal period, or at least 3 times per day. At least 3 times per day. When must filled reefers and refrigerators be defrosted? When do we got to defrost these things? When we have a frost accumulation on the coils that exceeds 1/4 of an inch. Frost accumulation that exceeds 1/4 of an inch. What temperature must filled reefers be at? Filled refrigerators got to be 40 degrees or below. If thawing at room temperature, what is the max temperature the room can be? If we're thawing at room temperature, what is the max temperature the room can be? Well, that's 80 degrees. We don't want the room to get above 80 degrees. If you buy produce from the local economy, what level of free available chlorine must it be soaked in? If you buy any produce from the local economy, what level of free available chlorine must it be soaked in? We can put it in 100 parts per million for 15 minutes, or we can put it in 50 parts per million for 30 minutes. What is the shelf life of an MRE? What is the shelf life of an MRE? An MRE has a shelf life of 48 months. 48 months. What are the 4 types of waste? What are the 4 types of waste? Our 4 types of waste are human waste, liquid, garbage, and rubbish. Human waste, urine and feces. Liquid, like the byproducts from showering or sculleries. Garbage, peeling, slicings, all the stuff from food. Rubbish, the packaging, the cardboard, and all that stuff in the packaging from our food products. What is used for human waste when troops are on the move? What is used for human waste when troops are on the move? We're going to use a cat hole. Cat hole for troops on the move. What are the dimensions of a cat hole? What are the dimensions of a cat hole? Well, a cat hole is going to be 8 to 12 inches in diameter and 6 to 12 inches deep. 8 to 12 inches in diameter, 6 to 12 inches deep. What is used for human waste and temporary bivouacs? What is used for human waste and temporary bivouacs? That's when we use a saddle trench. Saddle trench. How many people can a saddle trench serve? How many people can a saddle trench serve? It can serve 25 people. What are the dimensions of a saddle trench? What are the dimensions of a saddle trench? A saddle trench is going to be 4 feet by 1 feet and 2.5 feet deep. 4 by 1 and then 2.5 deep. How far apart are additional saddle trenches? If we're going to dig another saddle trench, we got to make sure we got at least 2 feet in between them. 2 feet in between saddle trenches. What can be used where soil conditions are hard, rocky, frozen, or the water table is high? Well, then we can use a burn barrel latrine. How far do any latrines have to be from a natural water source? How far do we got to keep latrines from water, natural water sources? That's 100 feet. 100 feet from a natural water source. How about any kind of berthing? We're going to keep latrines 50 feet from berthing, and then when it comes to food service areas, we've got to be 100 yards away. 100 yards. What's the most effective means of assessing the effects of heat stress on the human body? The most effective means of assessing the heat stress on the human body, we're going to use a WBGT index, the Wet Bulb Globe Temperature Index. What WGBT index correlate with the following flag? So a white flag is going to be below 80, right? Less than 80 degrees on the WBGT index. Green flag, a green flag is going to be from 80 to 84.9, 80 to 84.9. Yellow flag Yellow flag is going to be 85 to 87.9, and then a red flag is going to be 88 to 89.9, because a black flag is 90 and above. 90 and above. Once you hit 90, you're a black flag. So white flag less than 80, green flag 80 to 84.5, yellow flag 85 to 87.9, red flag 88 to 89.9, and then a black flag 90 and above. And then how much do we add to the WBGT index when wearing mop gear? When wearing our mop gear, we add 10 degrees. 10 degrees. All right, water supply afloat. How many gallons per day per man is specified for new ship design by NAVSEA? How many gallons per man per day? Well, that's 50 gallons. 50 gallons. What color must potable water sounding caps be? What color must potable water sounding tube caps be? They got to be dark blue. Water heaters serving like showers or lavatories cannot exceed what temperature? A water heater cannot exceed what temperature? It cannot exceed 120 degrees. How are potable water hoses labeled? How are potable water hoses labeled? Well, they're going to have the words potable water only on them, and those words are going to be in 1-inch letters, and they're going to be 10 feet across. Every 10 feet, it's going to say potable water only in 1-inch letters. All right, storage of HTH bottles, our calcium hypochlorite. We've got ready-use stock and we've got storeroom stock. Ready-use stock. How many days supply can be maintained in ready-use stock? We can only keep 7 days supply, no more than 7 days supply. How is ready-use stock stored? How do we store it? We got to store it in lock boxes mounted to the bulkhead, and those boxes got to have vent holes drilled into them 1/4 of an inch. All right, storeroom. Right, the room temperature in the storeroom stock cannot exceed what temp? It cannot exceed 100 degrees. All right, and then how many feet away must the storeroom stock be from any surface that can exceed 140 degrees? Any surface that exceeds 140 degrees, we got to make sure that we're at least 5 feet away. 5 feet away from that. How must lockers and bins containing HTH be labeled? How do we label lockers and bins containing HTH? Well, with a sign, right, with red letters on a white background that says hazardous material, calcium hypochlorite. Red letters on a white background, hazardous material, calcium hypochlorite. What is the shelf life of a bromine cartridge? What is the shelf life of a bromine cartridge? Well, bromine cartridge is good for 2 years. So remember, on the ship, a lot of times they use bromine to disinfect the water. You can test. They can either have chlorine or bromine. We call those halogens, but it's all the same when it comes to levels. We still get the same level of bromine as chlorine when it comes to disinfecting water on the ship. How are potable water hoses disinfected? How are potable water hoses disinfected? Well, we do that with 100 parts per million free available chlorine with a 2-minute contact time, and then after that, they're flushed with potable water. 100 parts per million for 2 minutes, then flush them with potable water. What level of free available chlorine should be reached in shipboard water that has a questionable taste or odor that cannot be identified? So we got a strange taste or odor in the water. We don't know where it's coming from. We want the tank to get up to 5 parts per million. 5 parts per million free available chlorine in the tank. And then the distribution system, we want to maintain 2 parts per million. 2 parts per million in the distribution system, 5 parts per million in the tank when we can't find the source of a questionable taste or odor of the water. Bacteria testing must be done on what percentage or fraction of the ice machines? All right, so we got to test the ice machines. We got to test 25% or a fourth weekly. 25% or a fourth of our ice machines got to be tested for bacteria weekly. For how long must the medical department representative maintain a chronological record of potable water surveillance? How long must the medical department representative maintain a record of potable water surveillance? They got to maintain that record for 2 years. 2 years, we got to keep records on water testing. All right, Decedent Affairs. Decedent Affairs from the Corpsman Manual. Who's the Navy and the Marine Corps' overall manager of the Decedent Affairs program? Who is the Navy and Marine Corps' overall manager of the Decedent Affairs program? Well, that's going to be Navy Casualty, Navy Mortuary Affairs. Navy Mortuary Affairs, the overall manager of the Decedent Affairs program. Who administers the Navy's Casualty Assistance Call Program? Casualty Assistance Call Program is administered by the Chief of Naval Operations Personnel Command, PERS, right? Personnel Command. Who administers the Casualty Assistance Call Program for the Marine Corps? The Casualty Assistance Call Program for the Marine Corps is administered by the Commandant of the Marine Corps, the CMC. What are the Decedent Affairs programs? Our Decedent Affairs programs are going to include Current Death Program, Graves Registration, Concurrent Return Program, and the Return of Remains. Current Death, Graves, Concurrent Return, and the Return of Remains. Which program is normally operational on a worldwide basis during peacetime? Well, that is our Current Death Program. Which program combines the Current Death and the Graves Registration Program? A combination of Current Death and Graves? Well, that's our Concurrent Return Program. Which program provides search, recovery, evacuation to temporary cemeteries? Temporary cemeteries, that's going to be our Graves Registration. Temporary cemeteries, Graves Registration. Which program is activated upon an enactment of special legislation and can establish permanent American cemeteries overseas? Permanent American cemeteries overseas, Return of Remains. Return of Remains programs. Which program provides for the permanent disposition of remains to persons buried in temporary cemeteries who could not be evacuated under the Concurrent Return Program? Bringing people home who could not be evacuated under the Concurrent Return Program, that's Return of Remains. So Return of Remains, remember, special legislation, and we're either going to bring home to them by establishing American cemeteries overseas, or we're going to bring people that were not brought home before under the Concurrent Return Program. Which program is only operational when authorized by the responsible commander during major military operations? When authorized by the responsible commander during major military operations, that's our Graves Registration. Graves Registration. All right. Within how many hours must a CO submit a casualty report? If a unit sustains a casualty, how many hours does a CO have to submit a casualty report? They got 4 hours. 4 hours for the casualty report. What method is used to submit a casualty report? What method is used to submit casualty reports? Well, that's going to be a priority message. Casualty reports are sent priority message. Where do casualty reports get sent? Where do they send casualty reports? Well, they send them to the Commander of Navy Personnel Command, and they get sent to BUMED, Chief Bureau of Medicine and Surgery. Between which hours should the PAD receive notification? Between what hours should the personnel authorized direct disposition receive notification? Well, we want to do that between the hours of 05 and 2400. 05 and 2400 is when notification should be made. When a death occurs CONUS, when a death happens in the United States, who is responsible to make sure personal notification is made? Whose responsibility is it? Well, that's the member's CO. The CO is responsible CONUS. Who will notify the designated Casualty Assistance Call Program regional headquarters when a death occurs OCONUS? When a death happens overseas, well, that's going to be NAV-PERSCOM who reaches out to the Casualty Assistance Call Program to make sure that happens. COs are required to write a letter of condolence within what time frame? COs got to get the letter of condolence done within 48 hours. Where are copies of the condolence letter going to be sent? Where are copies of the condolence letter sent? They're going to be sent to NAV-PERSCOM, right, Navy Personnel Command, and then JAG, the OJAG. All right, how frequently will progress reports be made to BUMED and Navy Casualty Office when search and recovery operations continue for more than 36 hours? Well, BUMED and the Casualty Office is going to be updated every 24 hours. Every 24 hours. Annual contracts are awarded to funeral directors when an activity anticipates how many deaths a year. Annual contracts can be awarded to funeral directors when an activity anticipates at least 3 deaths or more. 3 or more deaths a year. What type of expenses are incurred in connection with the funeral and the burial of remains? What type of expenses are incurred in connection with the funeral and the burial of remains? Well, that's going to be a secondary expense. What expenses incurred in connection with the recovery, preparation, and encasement of remains? Recovery, preparation, and encasement of remains, that is a primary expense. Primary expense. At what temperature can remains be refrigerated to minimize cellular deterioration? Right? At what temperatures can we refrigerate remains? We put it at 36 to 40 degrees. 36 to 40 degrees. What form is a certificate of death overseas? What form is a certificate of death overseas? That's our DD 2064. DD 2064, death overseas. How many copies should accompany the remains? How many certificates of death accompany the remains? 3 copies. 3 copies of that DD 2064. What form is a statement of recognition? Statement of recognition is DD 565. 565. How many copies accompany the remains? How many statements of recognition? Two. Two DD 565s. What are the internal dimensions of a standard casket? What are the internal dimensions of a standard casket? A standard casket should be 23 by 78 inches. 23 by 78 inches. What are the internal dimensions of an oversized casket? An oversized casket should be 25 by 81 inches. 25 by 81 inches. How will a casket be labeled if the death is a result of a communicable disease? How is a casket labeled if the death is a result of a communicable disease? It's got to be with a gum 2x4 label marked contagious. 2x4 label marked contagious placed at the head. When inventorying personal effects of the deceased, how many people must be on the inventory board? 2 people on the inventory board. What are the rank requirements? What are the rank requirements? One's got to be a commissioned officer. What is the inventory recorded on? What do we record the inventory on? Well, that's on NAV Sup Form 29. NAV Sup Form 29 for the inventory. 2 people on the board. One's got to be a commissioned officer. What type of expense is for when remains are non-recoverable? When they cannot recover the remains, they're going to do a memorial service expenditure. Memorial service expenditure. What form is the record and preparation and disposition of remains OCONUS? The record of preparation and disposition of remains OCONUS is your DD 2062. DD 2062. What form is the record and preparation and disposition of remains CONUS? That's a DD 2063. CONUS 2063, OCONUS 2062. Where do our casualty reports get sent? Right, when there's a casualty, where are the reports sent? They're going to be sent to the Commander of Navy Personnel Command and Chief of BUMED, Bureau of Medicine and Surgery. Where are the copies of the condolence letter sent? The condolence letter gets sent to PERS, right, NAVPERSCOM, and OJAG. What form is a certificate of death overseas? Certificate of death overseas, DD 2064. What form is a statement of recognition? 565, DD 565. What's the inventory recorded on? The inventory is recorded on a NAV Sup Form 29. What form is the record and preparation and disposition of remains OCONUS? Preparation and disposition of remains OCONUS, DD 2062. Preparation and disposition of remains CONUS, DD 2063. All right, talking some physicals from Chapter 15 in the Corpsman Manual. Physical exams. What is a report of medical history? What is a report of medical history? Medical history is going to be done on a 2807, DD 2807. Report of medical exam, well, that's a DD 2808, DD 2808. What is the report of medical assessment? The report of medical assessment, that's going to be done on a DD 2697, DD 2697. What form is the abbreviated temporary limited duty medical board and report? So this is the form that puts people on LMDU, right? LMDU is a Navy program, so it's a NAVMED form, has to do with physical readiness, 6100/5. Or your abbreviated temporary limited duty medical board report, that's on a 6100/5 NAVMED form. What form is a medical, dental, and educational suitability screening for service and family members? What form is a medical, dental, educational, and suitability screening for service and family members? Well, that is a NAVMED 1300/1. What is used to evaluate near visual acuity? What is used to evaluate near visual acuity? We're going to use Jaeger cards. Jaeger cards for near visual acuity. What can test both distant and near visual acuity and assist in evaluating other optical conditions? We can use the Armed Forces Vision Tester, the AFVT, Armed Forces Vision Tester, to do both near and far vision and also other optical conditions. What are the 2 methods for testing color vision the Navy has? What are the 2 methods we're going to use? We're going to use the Phallant, right, the Farnsworth Lantern test, or the pseudo-isochromatic plates, the PIP. What's the preferred test for color vision? The preferred test is your Phallant, right? Your Farnsworth Lantern test. What is the reference audiogram? Reference audiogram, DD 2215. DD 2215. What is the hearing conservation data form? What is the hearing conservation data form? Well, this is the form your annual audiograms are going to be done on. This is your DD 2216. DD 2216. What instruction is the suitability screening, medical assignment screening, and the EFMP identification and enrollment instruction? Well, that is our BUMED instruction 1300/2 Bravo. BUMED instruction 1300.2 Bravo. What form is the medical, dental, and educational suitability screening for service members and family members? Well, that is our NAVMED 1300/1. What's the medical, dental, and educational suitability screening checklist and worksheet? Well, the checklist and worksheet, NAVMED 1300/2. What form is the report of suitability for overseas assignment? The report of suitability, well, that's done on a PERS form. That's NAVPERS 1300/16. NAVPERS 1300/16. What form is the report of medical history? History is 2807, DD 2807. What form is the exceptional family member medical summary? Exceptional family member medical summary, that's going to be done on a DD 2792. What form is a special education and early intervention summary? That's a DD 2792 TAC 1. 2792 TAC 1. How much time does a family member have to complete their suitability screening after receipt of orders or overseas screening notification? How much time does a family member have? They got 60 days to get it done. How much time does a service member have to complete their suitability screening after receipt of orders or overseas screening notification? Well, they only got 30 days, right? 30 for the service member, 60 for the family member. What is the rank requirement for your suitability screening coordinator? What is your rank requirement for the suitability screening coordinator? That's going to be an E6 or above, right? E6 or above, appointed in writing, got to be in the position for at least 2 years. If the gaining command determines they do not have the capabilities to support a service member, who do they submit the unsuitability recommendation to? If a gaining command determines they cannot support a service member, who do they submit the unsuitability recommendation to? Well, they route that up to the TICOM surgeon's office. TICOM surgeon's office. How many days does the gaining suitability screener have to reply to a suitability inquiry? So when command sends, they got somebody they're questioning when they're doing the overseas screening, they send it to the overseas suitability screener. How many days do they have to respond to that? They only got 7 days. 7 days to respond to that inquiry. How far must an MTF be away from the command before it is considered a remote duty? How far must an MTF be away from the command to consider that command a remote duty? A 2 hours drive at normal conditions. 2 hours drive in normal conditions. Don't mix that up with TRICARE Prime Remote, okay? TRICARE Prime Remote, to get TRICARE Prime Remote, it's 1 hour's drive or 50 miles. But when we're talking about BUMED 1300/2, when we're defining remote duty, it's a 2 hours drive from the command to the hospital. What services are designed to meet physical, cognitive, communicative, social, and emotional needs of infants and toddlers? What services? That's the early intervention services. What is a written plan for preschool and school-age children that outlines special education programs that is required to meet the needs of the student receiving special education? Well, that's going to be our individual education plan, our IEP, our individualized education plan. What is a written plan for the family or an infant of a toddler receiving early intervention services? What is their written plan? Well, we get the family involved. So it's the individualized family service plan. Individualized family service plan. Who makes the final determination if a family member is unsuitable due to declining an immunization? Who can make that final determination if a family member is unsuitable due to declining an immunization? Well, that's got to be done by a BUMED flag officer, right? So flag officer from BUMED Family and Readiness. What is the minimum rank requirement for your EFMP coordinator? What is your minimum rank requirement for an EFMP coordinator? Well, EFMP coordinator has got to be an E5 and above, right? Same thing though, 2 years in the job, and then designated in writing. When should a post-pregnancy suitability screening be done on a dependent mother and newborn? When should a post-pregnancy suitability screening be done on a dependent mother and newborn? Well, that should be done 8 weeks post-delivery. 8 weeks post-delivery. Within how many days must the transferring command administer a pregnancy test to a transferring servicewoman? How many days does the transferring command have to do their pregnancy test on a servicewoman? Well, they should do that no more than 30 days out. No more than 30 days out. What form is the exceptional family member medical summary? Your EFMP medical summary, that was a DD 2792. Who must the gaining command notify if a screening deficiency is identified? So if somebody makes it overseas, and that gaining command notices, hey, something should have come up on your overseas screening. This person shouldn't be here. Well, they're going to go ahead and let the parent command know, and they're also going to notify BUMED Family Readiness. BUMED Family Readiness. All right, areas designated as I hazardous. Areas designated as I hazardous, how are they labeled? Well, we've got to put a 3-inch black and yellow stripe or checkered tape, and then we got to put a sign up that says caution, eye protection required in this area. Eye hazardous areas should have 3-inch yellow or striped tape right there on the deck, or it can be painted that way, and it's got to have a sign that says caution, eye protection required. Um, who certifies our eye protection? What standard does our eye protection have to meet? It's got to meet ANSI, the American National Standards Institute, ANSI. If it meets ANSI requirements, how is it going to be labeled? It's going to be labeled with the Z87 or Z87 plus. What is the how far away should emergency eye wash stations be from areas that are designated eye hazardous? Emergency eye wash stations should be no more than 100 feet, right? They should be on the same level within 100 feet or 10 seconds travel time. 10 seconds travel time. What's the flow rate emergency eye wash stations should be able to furnish? Emergency eye washes should be able to put out 0.4 gallons per minute for 15 continuous minutes. 0.4 gallons per minute for 15 continuous minutes. How high off the deck should emergency eye wash stations be? Should be 33 inches off the deck. What's the maximum height they should be? No more than 45 inches off the deck. And then what color should the sign be for emergency eye wash stations? Emergency eye wash stations should have a green sign with white lettering. Green sign with white lettering. An order of preferred application. What are the 4 principles of hazard control? What are the 4 principles of hazard control? The 4 principles of hazard control are substitution, engineering controls, administrative controls, and PPE. Which method of hazard abatement employs special operating procedures to reduce the exposure of individuals to hazards? Special operating procedures, that's an example of administrative controls. Administrative controls, like limiting the exposure, limiting the time somebody can go into a certain workspace. Machine guards, electrical installations, sound barriers, and remote control equipment are examples of what method of hazard control? Well, this is an engineering control, and more precisely, the type of engineering control, we call that isolation. Isolation, which is a type of engineering control. Who must be contacted for substitution approval? If we want to use substitution, we've got to contact ComNav Sea System Command or ComNav Air System Command. Which method of ventilation is preferred and more economical? Which method of ventilation is preferred and more economical? Well, we say local exhaust is preferred and more economical. What is substitution? What is submitted in order to replace a tool or material on a material requirement card, an MRC? What's required? What do we got to submit to replace a tool or material? Well, we got to do a PMS feedback report, a planned maintenance system feedback report. What method of hazard control is the least preferred? What method of hazard control is the least preferred? Well, that's our PPE. That's the least preferred. Where are hazards that cannot be corrected on the spot documented? If we cannot correct a hazard, it's got to be documented in the Work Center Deficiency Log, job sequence number, the WCDL JSN, Work Center Deficiency Log, job sequence number. What form is our safety and hazard report? What form is the safety and hazard report? That's an OpNav, and that's OpNav 3120/5. 3120/5. What is derived from the elements of the hazard severity and mishap probability? What can we get when we look at a hazard severity and its probability? Well, we can get a risk assessment code, a RAC, risk assessment code, when we take the severity and the probability. How many risk assessment codes are there? How many risk assessment codes are there? We say there's 5. What are the 5 risk assessment codes? The 5 risk assessment codes. So level 1 we say is critical, RAC 2 serious, 3 moderate, 4 minor, and 5 is negligible. Right? 1 critical, 2 serious, 3 moderate, 4 minor, 5 negligible. What are the letters designated to mishap probability? So remember, probability, we go A, B, C, D, A being the most likely to occur. So we say A is likely to occur immediately. B probably will occur in time. C may occur in time. And D unlikely to occur. A likely to occur immediately. B probably in time. C may occur in time. D unlikely to occur. What are the hazard severity categories? So severity categories, we number them in Roman numerals. 1, catastrophic. 2, critical. 3, marginal. 4, negligible. Again, 1, catastrophic. 2, critical. 3, marginal. 4, negligible. All right, this wraps up this review session. We covered a lot of ground. We talked quality assurance, regulated medical waste, respirators, hearing conservation, deployment health assessments, malaria, periodic health assessments, pharmacy ops, the Med Inspector General Program, primary care medical surveillance, preventative medicine for ground forces, water supply afloat, decedent affairs, physicals, suitability screening, medical assignment screening and EFMP, site protection, and hazard control. So like I said, this wasn't meant to be detailed lessons like the previous videos. If there was anything on there that you needed to learn a little bit more in depth, a lot of the stuff I do have presentations on, or I'm planning on making some of the new stuff I covered. Like I said in the beginning of this is just a review session. This is stuff me and my guys have been hitting up every single day. So with that, I hope this helps. Keep studying, especially you, Frazier. And all you guys that have been coming to the study sessions, Frazier, Thompson, Harris, Gonzo, Ward, Earl, you guys better pick up off this cycle. All right.